Hey, you are listening to Medica Talks, which brings to you all the exclusive healthcare industry news, views, and opinions from across the world.
Hello listeners, I'm Urvashi. Today, we will discuss about Upper Airway Management in detail by Dr. Anjoo Choudhary, who is life member of Otorhinolaryngologists, Laryngology, and Voice Association of India. She is an airway surgeon attached to SRCC, Saifee, and Prince Ali Khan Hospital. Hello, Dr. Anjoo Choudhary. Welcome to our podcast for patients, caregivers, and healthcare professionals at Medica Talks. Hello, ma'am. Can you please tell us what is the meaning of airway?
Hello everyone, wishing you all a very happy Doctor's Day.
Thank you very much for listening to the podcast. To begin with, the human airway starts from the nose, goes behind in the throat, and down into the voice box or the larynx, where there are two vocal cords. These two vocal cords they open up to give supply to the supply oxygen to the lungs, and they close to produce good voice. Then, as we go down into the windpipe or the trachea, which goes into the chest and divides into two parts, that is right and left bronchi, to supply oxygen to both the lungs. So this entire passage of air is collectively called as the airway. We divide this into upper and lower airway. The nose, throat, larynx up to the trachea or the windpipe is called the upper airway, and the rest is called the lower airway. So the disorders of the upper airway are treated by ENT or airway surgeons, while that of the lower airway are treated by pulmonologists.
What are the functions of the upper airway?
Every part of the upper airway has specific functions. Like for the nose, the most important function is sense of smell or olfaction, but it also helps in drainage of sinuses. It is also needed for filtration and humidification of air, and it protects the lower airway. It also has a major role in resonance of voice. The throat is a common conduit or passage for air and food. The larynx or voice box has three main functions. One is breathing or respiration, where the vocal cords open up maximally to give oxygen below. Voice production, that is when the vocal cords close together to produce a loud noise or voice. And last and very important function is prevention of aspiration, that is protection of the lungs while swallowing by closure of the vocal cords. So when we eat anything, the vocal cords come together tightly to protect the airway, so nothing goes in the windpipe and everything goes behind into the food pipe. The last part of the upper airway is the trachea or the windpipe, and it is a semi-rigid tube for passage of air into the lungs.
What are the causes for upper airway obstruction?
So if we talk of causes of upper airway obstruction, then we can say that any mass or any foreign body or anything that compresses the airway from inside or outside and results in reduction in the lumen of the airway will cause these kind of problems. It can be at any side starting from the nose up to the trachea. So if we talk of common causes of upper airway obstruction, they are either birth related defects or some acquired lesions which are seen after the birth. Those coming to us very early in their life in the neonatal period, they present with common symptoms like obstruction in the nose caused by a disease called choanal atresia, which is blockage of the opening of the nose from behind. Or sometimes some children are born with disease, syndromic diseases where the jaw is not developed properly and it falls behind and the tongue is large which obstructs the airway from above. Or it can be common conditions like laryngomalacia, which is softening of the airway. This is a very common condition. It's the most common condition causing noisy breathing in young neonates. They present at around 6 weeks of life. Or the second most common cause would be both the vocal cords not moving properly. They are not opening properly, resulting in some noisy breathing. Then one of the important causes also is subglottic stenosis, that is narrowing just below the vocal cords. There can be some webs which are holding the two vocal cords together, or some cysts or masses in the airway, or it can be in general a narrowing of the windpipe, which is called congenital tracheal stenosis. If we talk of acquired causes, In the nose, the most common would be adenoid hypertrophy. Adenoids are like tonsils, but they are present in the nose, behind the nose. So when these are enlarged, they result in something called as mouth breathing or upper airway obstruction. And when the child sleeps, he has problems in breathing. There can be some polyps in the nose because of allergies, which is common in these population, or some foreign body, or some trauma to the nose while playing. There can also be tonsillar enlargement or hypertrophy resulting in obstruction at that level. There can be some masses or some pus collection in the tonsil causing some obstruction in breathing. Another most important cause in the acquired variety is post intubation. Children or adults who are born normally but later on are intubated or kept in the ICU with a breathing tube for a long period of time. After getting better and out of the ICU, once these tubes are removed, they develop certain narrowing at the level of the cuff of the tube or where the tube rubs inside the airway, and they present with a slow narrowing of the windpipe. Then they present with a breathing sound which is specific of obstruction, which is stridor. I'll explain it later. And uh, certain problems like trauma to the neck or some burns in the neck while playing or during firecracker injuries, these all can result in airway obstructions.
Who is at risk of upper airway obstruction?
The patient or the parents of children who have upper airway obstruction will typically present with noisy breathing and difficulty in breathing. Now, the causes of which I have already explained. Now, we look for different symptoms in these kind of patients. When the obstruction is at the level of the nose, they can present with recurrent rhinitis or cold, cough, sneezing. They can also present with mouth breathing when there is an obstruction behind the nose with adenoid tissues. They can present with snoring in the night, which is also a very important symptom in children as well as in adults. But in children, when these adenoid hypertrophy results in obstruction of the nose, they present with loud snoring and mouth breathing. They also present with stutter. It's a specific kind of sound which is produced when the nose is blocked from behind. It's something similar to snoring. It's a low pitched noise like this. This is called stutter. They can sometimes present with foul smelling nasal discharge if they have foreign body in the nose, or they can have change in the nasal twang or the quality of voice. If the obstruction is at the level of throat, then they can present with difficulty in swallowing, difficulty in breathing, or sometimes drooling or saliva. At the level of the voice box, the most common symptom would be hoarseness of voice, certain breathing difficulties if there is an obstruction, or when both the vocal cords are paralyzed and they cannot open very well, then they present with stridor. Stridor is a high pitched sound of obstructed windpipe. Sometimes they also present with a washing machine kind of sound, which is suggestive of aspiration, which means that when a patient eats or drinks something, the food or water, instead of going into the food pipe behind, accidentally comes into the windpipe, and by reflex mechanism of coughing, they typically present with cough on eating. If they cannot protect their airway by closing of the vocal cords, then this secretions or water or food can sometimes go into the windpipe, and then it gives rise to a washing machine kind of sound, which is like this. This suggests aspiration. So these are dangerous and difficult situations because once these secretions go into the lungs, they can result in life-threatening pneumonias. So, and as we go lower down into the windpipe, if there's an obstruction at that level, the patient will present with a stridor kind of sound, which I explained is a high pitched sound of an obstructed windpipe. It's like this. So that means that the windpipe is getting obstructed, and during inhalation or breathing in and breathing out, both the times there is this typical sound how we blow air through a narrowed pipe that is called a biphasic stridor. So to sum it up, any noisy breathing with difficulty in breathing or any hoarseness of voice or cough while eating and swallowing or any indrawing of chest and neck should alarm the patient and the parents that there is some upper airway issue.
How does an individual know that he is suffering from upper airway obstruction?
When a patient or the parents of a child suspect some kind of upper airway problem, they should immediately report to an ENT or airway surgeon. Based on the different types of sounds that I explained, and based on the severity of the patient's problem, the ENT or airway surgeon will do a small endoscopic assessment. An endoscopic assessment is a very simple and quick test done with a scope, which is a very fine scope. The scope passes through the nose, goes behind into the throat, up to the level of the vocal cords, and sees what the problem is on the camera. Once this is done, they can assess what is the level of obstruction and how much is the obstruction. It does not require anesthesia, it does not require admission, it can be done on an outpatient basis. Only very small children require certain amount of anesthesia for the same. Sometimes a CT scan of the neck is needed to diagnose such cases, like for example, certain masses or certain vessels which are obstructing the airway from outside, or injuries to the neck. These cases need a CT scan. Once this examination is complete and the airway surgeon has fair amount of idea what the obstruction is, the patient needs to be examined under general anesthesia for the treatment of the obstruction. Either it can be done in the same setting or it can be staged.
How is upper airway obstruction diagnosed?
The treatment of these conditions is again based on the site of obstruction and severity of obstruction, and it has to be tailor made for each patient. For example, the most common cause of pediatric obstruction is laryngomalacia, that is softening of the airway and above the level of the vocal cord, and it becomes so floppy that it closes the opening of the vocal cord every time that the child breathes. So 70 to 80% of these cases will recover on their own once the child grows and attains certain amount of rigidity in the airway. So the treatment is simply wait and watch. All we needed to do was a quick endoscopic assessment, and confirming that this is our diagnosis, we just advise the parents to wait and watch patiently till the child grows. In adults, the most common cause is the iatrogenic trauma or trauma caused by the intubation tube in the ICUs. So, if these cases are detected early by an endoscopic assessment, then we can do a small procedure and remove the obstruction from within inside and not open up the neck or do any major procedure. But if these patients present to us late, then the airway becomes quite narrow and they present with severe obstructive breathing, then we may need to do a tracheostomy. A tracheostomy is a procedure on the neck where a small nick is made on the windpipe and a tube is passed below the level of the obstruction to bypass this obstruction so that the patient can breathe normally. However, removal of this tracheostomy then is a very long, complex, delayed, multi-stage procedure of the windpipe. So, if these patients come to us early, then the treatment can be from within, endoscopic, and we avoid major open surgeries.
How can upper airway obstruction be treated?
So, like I explained, that these obstructions result in reduced oxygen supply to the lungs, and thus they can be life threatening if the treatment is delayed. So, they do need immediate to urgent management based on severity. When they are treated early, the treatment is minor, basic, like endoscopic dilatation or removal of the mass, and there are no external scars or surgeries. However, if it is delayed, then we do need to do tracheostomies for such patients. Once a tracheostomy is placed in the neck, the patient loses the capacity to speak. He has to clean and maintain the tube regularly. It is a long-term thing. Removing these tracheostomy requires multi-step surgeries and need lot of expertise. It needs interdepartmental coordination for best results. So definitely if they present very early to us and they are aware of all these problems, then we can also help them in a quick and efficient way.
So, what message would you like to give to the listeners?
Through this podcast, I want to convey this to all the listeners that upper airway obstruction presenting with noisy breathing is a potentially life-threatening problem, and an immediate consult with ENT or airway surgeon is warranted. It is complex but treatable disease and when diagnosed promptly and appropriately by simple endoscopic measures. Thank you so much for listening.
Thank you, Doctor, for being a part of Medica Talks and sharing your insights. We are hopeful that the importance of Thank you, doctor, for being a part of Medica Talks and sharing your insights. We are hopeful that the importance of airway management mentioned by you will help in saving lives.
Hey listeners, I hope this podcast was beneficial for you. Don't forget to stay tuned with us for our next podcast session, where we bring to you all kinds of healthcare industry news, views and opinions from around the world.